The situation in the state of Illinois with regard to health care is unfortunately no less complicated and fraught than the other issues that you'll be hearing about and that this overall project has highlighted. So just to give you a little bit of background, the state spends roughly just under $7 billion on healthcare. That's the actual state dollars that are accounted for healthcare. Much of this is the Medicaid program, and nearly all of it. And the bulk of it is on medical assistance, though a good chunk is still long-term care. In terms of where Illinois on per enrollee spending ranks, it's pretty much in the middle, if not a little bit below, according to some of the most recent numbers we could get. In general, though, that's driven really by the fact that for the aged population, Illinois is considerably below the national average, and that's likely owing to Illinois' lowest in the nation Medicaid long-term care reimbursement rate. So that's a little bit of the background. Of course, many of you, I'm sure, have heard of the Affordable Care Act, and that has changed things and will continue to change things going forward. So specifically, the efforts to enroll the uninsured will increase Medicaid enrollment, as well as increasing private enrollment in the health insurance exchanges in Illinois. The newly eligible Medicaid enrollees, I'll distinguish between those newly eligible versus those who were eligible and get enrolled as a result of the effort to make sure that people have health insurance coverage. The newly eligible Medicaid enrollees will be entirely federally subsidized for the first few years, and then beyond that, the feds will pay about 90% of their costs. For the other previously eligible Medicaid enrollees, the states and the feds will split the cost 50-50. So there will be expenses there on the part of that Illinois will have to pay for going forward. The policy options, though, in Illinois are a bit limited at this point. Elizabeth just talked about one aspect of this law, the SMART Act, Save Medicaid Access and Resources Together, which, among other things, lowered provider payments, increased user fees, and other changes here included efforts to fight fraud in the Medicaid program. And you heard about the somewhat limited success from Elizabeth about that program. So, this nevertheless was a law that tried to get at the remaining low-hanging fruit in the Medicaid program in terms of spending reduction options, and the bottom line is that it's hard to wring any more savings out of the program. So, and as I already indicated, Medicaid nursing home reimbursement is already the lowest in the nation, so it can't easily go much lower than that. The state is pinning its hopes largely on care coordination efforts to save money going forward with Medicaid, and the goal is to facilitate better patient-provider communication, but there's reason, though, to be skeptical that much in the way of savings can be realized from these efforts. One well-done study by the Congressional Budget Office of 30 different disease management and care coordination programs found that they were really just as likely to increase costs as they were to decrease costs, and overall the program had no effect on the different programs had no effect on spending. In terms of solutions, then, where does that leave us going forward? As I've alluded to here, there's little reason really to be optimistic about the state's chosen approach. And the question then is, well, do we want to look to more radical solutions going forward. The one example that we can take from another state, and this is just starting, is in Arkansas, which has been on the forefront here of the so-called private option model, where the effort is essentially to enroll all Medicaid, to basically fold the Medicaid program into the state health insurance exchange, and so really to not in any way cash out of Medicaid, but really to move Medicaid enrollees into private health insurance plans. And so Arkansas got a waiver to do this, and it's very early, but there are two authors here in Health Affairs Journal had commented that there's some reasons to be optimistic about this path, and obviously this would be a very involved choice for the state, and also fraught with many concerns along the way. So the overall final thoughts that I can offer is that the state's rather timid approach to cost control, we think, is unlikely to yield meaningful savings for the Medicaid program going forward. Spending will continue. There will be sources that increase that spending above and beyond the demographics of the aging population, but in also the form of new enrollees into the Medicaid system. And then the real question, I think, before the state is whether broad, out-of-the-box type thinking is going to be required to find some real savings and prevent Medicaid from continuing to consume ever larger fractions of our state's spending.